think we'll go ahead and get started. So welcome to today's seminar. It's hosted by the College of Public Health and Human Sciences at Oregon State University. I'm Marie Harvey. I'm the Associate Dean for Research in the college, and I'm very pleased to welcome everyone. And I'm also pleased to introduce Javier Nieto. He is the Dean of the College of Public Health and Human Sciences, and he's co-principal investigator on the TRACE study. Javier will be introducing our speakers today, and he will be moderating the session. So with no further delay, please join me in welcoming Dean Nieto.
Thanks, Marie, and welcome everybody to our research seminars and for joining us today via Zoom. And now let me introduce today's speakers. Dr. Ben Dalziel is assistant professor in the Department of Integrative Biology at the OSU College of Science. Ben specializes in the dynamics of epidemics, specifically the factors affecting the emergence, spread, and control of infectious diseases. He has extensive experience leading international studies on transmission dynamics of measles, Ebola, influenza, and coronavirus. And then Dr. Jeff Bethel, Associate Professor in the School of Biological and Population Health Sciences at the College of Public Health and Human Sciences. Ben is an infectious disease epidemiologist with particular interest in the area of emergency response to infectious disease outbreaks and natural disasters. Before OSU, he worked as an epidemiologist at the CDC, conducting infectious disease surveillance and pandemic influenza planning. Ben and Jeff are going to give us an update about TRACE COVID-19, or TRACE for short, which stands for Team-Based Rapid Assessment of Coronavirus Epidemics. I just wanted to mention quickly that this has been an extraordinary effort in terms of both scope and expediency. In just barely 2 months, TRACE went from inception to seeking and obtaining funding, protocol development, developing bilingual study materials and data entry and management systems, solving laboratory licensing issues, obtaining IRB approval, hiring and training personnel, establishing a call center, and going into the field and completing the collection of samples from thousands of individuals over 4 weekends in 2 communities, Corvallis and Bend, in just 2 months. This involves the collaboration of scientists in 5 OSU colleges, and I think this is very important to highlight in the spirit of the collaborative nature of OSU. It involved colleagues, scientists from science, from public health and human sciences, from engineering, agricultural sciences, Carlson College of Veterinary Medicine, Center for Genome Research and Biocomputing, plus the research office, the OSU University Relations and Marketing, the Office of Legal Counsel, the OSU Foundation, Benton and the Deschutes County Health Departments, and Willamette Valley Toxicology. All this made possible to a great extent by the leadership of these 2 outstanding scientists presenting today. So Ben and Jeff, it's all yours.
Thank you, Javier. And thank you to Marie and everyone for inviting us to present. Yeah, let's just get started here. Jeff and I will tag team through this presentation, which is really, as Javier mentioned, this is all happening quite quickly, and this is an update as we're still in process of some of the things that have happened over the last 2 months and sort of where we are and a little bit of where we're going with the TRACE project. It is indeed a massive collaboration, and I'm looking forward to highlighting some of the elements of that. I'll also just say really quick that indeed I'm actually, in my own position, I'm a cross appointment between integrative biology and the mathematics department as well. So see if I can advance slides here. Okay, so we have the TRACE leadership team consists of Jeff and I as co-directors, Associate Director Kathy Higley, and then 6 other truly amazing co-principal investigators, including Javier, Jane Lipchenko, Brett Tyler, Javier Nieto, Dean of College of Science, Roy Haggerty, Justin Sanders, Tyler Rudnicki, and these folks, many of you will know probably most of them. We have the deans of two colleges here, the head of the Center for Genome Research and Biocomputing, the former head of NOAA, distinguished professor, faculty from across, as Javier said, many different colleges. And that's really what's made this possible, is this massive collaborative effort between people coming in with different expertise and working to solve a bunch of challenges as we tried to do the project. We also benefit from support from a wonderful team of senior personnel. So Aslan Noakes, our field manager, Allison Myers, who directs the call center, and Christine Kelly, who's on the wastewater project that we'll talk more about later, Denise Hines, who brings expertise in data security, management, analyses of big data sets for health, and Ziyu Young, who's our project manager and wizard of logistics of all kinds, and many other people who we'll highlight throughout the talk here. Probably the best part of 100 people work on TRACE and make it possible. So I probably don't need to spend too much time. As you know, coronavirus is an infectious respiratory pathogen. It's responsible for, well, you all know what it's responsible for to some extent. It causes a range of symptoms that we know about. But what I want to highlight here is in many people, infections are asymptomatic or just involve mild symptoms, and yet those folks can be part of chains of transmission. And that was one of the sort of key pieces of why we started to initiated the TRACE project. It's the way that testing is set up. It's really difficult to know how many people are actually infected in the community or what the community prevalence is, because testing has been limited, and it's been really focused on folks with symptoms or severe symptoms. And yet, even among the cases that we know about, the burden just in the US has been tremendous, as we all know. Over 100,000 deaths, approaching 2 million cases. And again, those are just the ones that we know about, and reporting rates are probably low. We've had 159 deaths in Oregon, and well over 4,000 cases. So with a testing gap and with variable testing, the case counts that were often reported in the media actually don't provide very much information on the prevalence in the population. The patterns in how many cases we're seeing in different places and how cases are changing over time largely reflects the way that testing is being conducted. Yet despite the fact that those case counts are often used as sort of stand-in for prevalence. And that's partly because they're the best we have, and it's in some cases, and it's partly because of perhaps some confusion among non-epidemiologists about the meaning of case count data. So, but given that case counts aren't a particularly reliable estimate of population prevalence, managing a pandemic without knowing essentially how many people are infected in the population is really difficult. And these were the sort of motivating thoughts behind the TRACE project, team-based rapid assessment of community-level coronavirus epidemics, to see if we could find a way to fill that gap, to gain an understanding, at least for Corvallis, and then one community at a time, scaling up of what, in as near real time as possible, what the prevalence was, both so that we could have situational awareness generally, and especially in the context of reopening, being able to understand how the reopening decisions we are making are affecting prevalence. And then that's really the key, right, to being able to do adaptive management of the reopening, the staged reopening. So, and to do this, we in the early conversations, and I think this has really come to pass, it's been thinking about the untapped potential of universities, and especially land-grant universities, and their communities to do something like this. The university has incredible resources and potential, all of the laboratorial expertise and equipment, all of the other types of expertise and equipment that are required to do a project like this exist within a university. And they're, of course, allotted across many different projects, but in an emergency like this, they certainly can be mobilized. I don't know if there are other Harry Potter fans in the audience. I don't even know if I'm a Harry Potter fan exactly, but there's this thing in Harry Potter called the Room of Requirement, which is this room, as I understand it, where it appears and you can get what you need from that room when you need it. And I sort of started to think of universities that way in the context of doing an effort like TRACE. There's this potential to serve the community with a lot of power and positive impact. In a context like this, sort of pull together to do something. So that's sort of one of the ideas behind what we're doing here. And Javier touched on that in his introduction as well. So the goals of the TRACE project are threefold. We want to estimate the prevalence of SARS-CoV-2, the virus that causes COVID-19, in a city in as near real time as possible across asymptomatic, symptomatic individuals, random, hopefully representative sample of the population. We want to do that in a way such that we're developing a scalable system that can be rapidly deployed to other communities. And last weekend, we partnered with Bend to start expanding TRACE to other cities. And we want to harness the untapped potential in universities and in their communities to adapt and respond to COVID-19, to be part of creating pandemic resilience in communities. There's many other aspects to that, but I think that these objectives can play a role. So a little bit about our approach. There is no I in TRACE. This is actually Jeff's joke. I think it's not a joke, it's true. So we want to take a moment and just acknowledge the many organizations and people that have made this possible, and also hopefully along the way tell the story of how it all works and how it came to be. So we are lucky to receive funding from the David and Lucille Packard Foundation, from Pacific Source Health Solutions. Early on in the project, we ran into a problem where to do diagnostic testing and report the results to individuals, you need what's called a CLIA certified lab. Of course, testing like that is regulated, as it should be. And even if one has, a qPCR machine, which is one of the key pieces of lab equipment you need to run the test, you can't just start testing people. That's a medical diagnostic service, and it's appropriately regulated, right? So that was a real sort of a hitting of a brick wall for TRACE in the early days, but we were saved through a really awesome creative partnership between Willamette Valley Toxicology, which is a private lab in town, and a collaboration with the Oregon Veterinary Diagnostic Lab, where Mark Ackerman's the director. And Mark worked really hard with Manny Cruz, who's the principal partner at Willamette Valley Toxicology, to find a solution where we could get a CLIA certified situation where we could do testing. And so it involved actually taking machines from the veterinary diagnostic lab, bringing them over to WVT, and working with them to set up a system so that we had a CLIA certified lab with the appropriate equipment and personnel, and making that happen. And it was a huge effort. And when that clicked into place, we really had the ability to start testing, which is, of course, the crucial ingredient. Another crucial ingredient is we partner with health departments in each community we go to. And so initially that was Benton County Health Department, where Dr. Bruce Thompson and Dr. Charlie Fountain, who are the director and the public health officer. Dr. Fountain's the director and Dr. Thompson's the public health officer. They worked with us they partnered with us to make TRACE possible. This is something that is a partnership with county health departments. It's the T for team-based and the C for community, and TRACE is really about these types of partnerships. And so that was a crucial element. Recently, we've partnered with OSU Cascades, which just represents another partner. We're going into, as we're going to test in Bend. The research office, VP RM Toomer and Associate Vice President Tuba Oskenhaller have, and in the midst of everything else that they're doing in a very, very challenging time for the university, have facilitated a lot of processes and troubleshooting moving really, really rapidly to allow this to be possible, including and sort of similarly, the Institutional Review Board at OSU has moved extremely rapidly to assist us in developing something that was appropriate and design and really going above and beyond in terms of the timelines that we're thinking about. And similarly for CGRB, Office of Information Security, and then when we get the data back, it's all entered by this wonderful team who works really long hours to enter all these paper data forms from the participants, hundreds and hundreds and hundreds at a time, getting us the sample sizes that we need. And at this moment, I'm going to turn it over to Jeff.
Thanks, Ben, and thanks everybody for coming to listen to our talk today and about the update on TRACE. Yeah, so just continuing on this theme, there's no I in TRACE. I'll be on the right side of your screen now. University Relations and Marketing, Steve Clark and his team, as well as Catherine Straupel and Tamara Cessna at the PHHS and College of Science Marketing Communications teams. They have been fantastic in getting the word out about TRACE. And I think that has resulted in part to our high participation rate that we've seen in Corvallis. So this is a unique project in that participants, as well as researchers, don't know who's going to participate until we knock on doors. So an important part of that component is to get the word out that TRACE is happening, so people are aware of our presence in the community and hopefully will participate. Terry Meehan, Office General Counsel, helped navigate some of these agreements between different agencies, in particular OSU and WVT, the lab is doing the testing. Allison Myers and her team at Center of Health Innovation and the call center that she sprung up quite quickly in response to our local health department's feedback. Thank you, Ben. Feedback about inquiries coming in from the public about this project, and as well as participants. So that was spun up very quickly. We have a slide about that later. So that was really important. OSU, Mark Hornibrook at OSU Student Health Services was instrumental in getting early on the project, getting our field teams tested for coronavirus before each weekend of data collection. Human Resources has been incredible in their responsiveness to the surge in hiring to get this project going quickly. Not only, I'll talk about the field teams later, but the hiring of our field team leads as well as our student workers who are in the field as well. So they've been an incredible partner. Similarly, the various business centers, in terms of hiring, printing and mailing. We have a lot of materials that needed to be printed, and they often, printing and mailing, did not have a lot of notice to get this done. So they have stayed late. They've been an incredible partner in this as well to get us what we need to be successful on each weekend of data collection. The motor pool, our teams are out in the community and using 30 12-passenger vans every weekend of data collection. And motor pool has made those available to us and been a great partner to work with. On the OSU School of Design Environment, as well as the Corvallis Sewing Brigade, two groups. I think there's others, I might have forgotten the other groups, but they provided us OSU themed maps for our teams in the field, as well as staff back on campus. So those have been nice to have, as help identify us with OSU in the community. Similarly, the Alumni Center has made their space available to us for our trainings, as well as our testing of field staff each week before data collection. And lastly, the OSU Foundation and their assistance in securing funding for this project. None of this would be possible without the funding, of course. So yeah, again, there's no iron trace, a lot of partners, and I apologize if we forgot any group, but the theme here is that many people involved in getting trace going quickly, as Javier mentioned.
Actually, Jeff, I did forget somebody, just sort of jump back in. Deschutes County Health Services and George Conway, Dr. George Conway, who's the health services director there. So as we've gone to Bend, it's a new community health, it's a new health department. And we have been working with Dr. Conway on analysis and on making it possible to be in Bend. So definitely want to say that too. Sorry to interrupt.
Next slide, please. So let's get into a little bit what we did. So, one of the benefits of trace is that it's rapid. We are not only do we quickly ramp it up, but more importantly, the assessment or the time period over which we collect our data is very quick. It's over 2 days on a weekend. So that really gives us the cross-sectional estimate of infection in a community. So again, we're just looking at, we have some sample survey techniques, again, to rapidly determine the health status of an affected community in a way that's representative, and it gives us information for actionable response. This information is useful for our partners at the respective health departments. Put this information in the hands of decision makers for them to act appropriately. And these methods of a rapid health assessment or an RHA, they're rooted in the 1970s efforts, to quickly assess immunization coverage in developing countries. So we think of this as that, it's really field work at its core, and it's a rapid health assessment. Oh, I tried to do the down arrow, and that's not going to work. Ben's driving. Thank you. In terms of sampling, habit. In terms of sampling, we first needed to identify an assessment area, typically identified by political boundaries, city limits. You could use geographic boundaries, proximity to a certain area like a coast, or select a specific community that's most affected by some type of disaster. In this case, we're talking a pandemic. Next step is to divide this assessment area into non-overlapping sections, and these are called clusters in our sampling design. Then we need a list of all clusters. That's our sampling frame within this assessment area. For us so far, that's been Corvallis city limits and Bend city limits. And then this is all leading towards a probability-based sampling scheme, which allows us to collect data from participants that are representative of the assessment area or the target population. Next, please. Yeah. So we used a 2-stage cluster sampling scheme. Again, really useful for field-based rapid health assessments that are conducted in the field. So the first stage is to select 30 clusters I just mentioned, and these are census blocks. And these are done with probability proportional to the number of housing units in each census block. And you can use GIS software or census data to do this. So that occurs before we go in the field. Stage 2 occurs in the field, and it's a 30 by 12 essentially approach. So within each of these 30 clusters, our teams will approach, will seek to collect information from 12 different housing units, and they use systematic sampling within each of the selected clusters. So we have an estimate of the number of housing units in each census block or in each cluster, divide that by 12, and that's our interval for that systematic sampling in the second stage. So we'll have a random start and proceed to the kth house. So there are 100 housing units in a given cluster, divided by 12. Interval is going to be 8. So next slide. So here's just in this example, the interval is 5, but we start up there in the upper left-hand corner, and our teams have a map similar to this, but with street names. And this is not a real census block, or that was used. And then they go to every 5th house within this census block, and they just keep working their way around to approach 12 houses. And then we'll have replacement of houses for refusals, and we will revisit houses at least 2 times before we then replace them. Next slide. So in terms of our field teams, this is my favorite part. These people are amazing, both members of our field team. So the team leads, we started off with traditional health workers, and we've expanded a bit into other allied or community health workers with a similar skill set, home visitors, nurses, nursing students, medical assistants. and that's a recent addition. But initially, our THWs, for those of you who aren't familiar with, these are it's an umbrella term for frontline public health workers. They're really a part of the community, and you see listed on the slide 5 different types of THWs. We've mostly used CHWs and birth doulas in TRACE thus far, and they are the in addition to the students, they are the ambassadors of TRACE in the community. They are knocking on doors, they are talking to people, they're potentially navigating some awkward conversations and addressing things, and they have just been amazing thus far, and will continue to do amazing work. We've been so happy to have all our team leads, and they just do amazing work, and we're fortunate to have them. Next slide, please. The second member of our field team are OSU students, primarily from College of Public Health and Human Sciences and the College of Science. Mostly at the undergraduate level. We have graduate students as well from the MPH program. And I think for undergrad or grad, I think these students are getting an amazing experience in an applied public health project. They're literally walking streets, knocking on doors, and collecting valuable data that's really going to make a difference, I think. So they're getting great experience, and they've been amazing as well. Next slide. So just quickly here, moving clockwise, starting the upper left, just some examples of some of our field teams. We have McLean and Catherine. McLean is a community health facilitator in the Peace Corps in Peru who had to come back early because of COVID, and we've been fortunate to have him in our team. Catherine is a community health worker. Upper right, we have Nina is a home visitor for Healthy Families Oregon. Chris is an undergraduate student in College of Science. The lower right, on the left side, that's Jessica, she's a nursing student at COCC in Bend. Julianne is an undergraduate student here at OSU. The lower left in the front, we have Christina as a community health worker for Bend County Health Department. And working our way back are 2 MPH students, Sarah and Courtney, showing their excitement to get going in Bend this past weekend. Just what is that? 9 examples here of the stellar work of our field teams. Next slide, please. And those are the people that are in the field, or examples, people in the field, back at our command center, we call it. On the left, Ben already mentioned Ashley Noakes, a graduate of the MPH program. Just want to point that out, who moves mountains to pull all this off. With her team on the right, Ezra, Laura, and Piper, you'll see the buckets that our field teams take out with them to all the supplies they need to get going. So this is it's a huge effort. I could spend an hour talking about all the details, but this team is amazing to work with. Next slide, please. So in terms of roles, responsibilities, the team leads, and I'll expand more on the next slide. They lead all the interactions, with the household in terms of introducing the project, informed consent, interview, and collecting the nasal specimen. The students lead the team navigation through the clusters or these neighborhoods. They keep track of all the forms, and there are a lot of them: consent forms, letters of support, the resource guide, leave behind materials that we have for all the households who decline or participate, as well as they maintain the specimen collection kits. And they're really need to have all this material at the ready to provide the team lead to do their work. And lastly, they're in charge of completing our tracking form for each house that we approach, and that's really important. We use that information to calculate our various response rates, which helps with our we report with our results in terms of, it gives us a degree of representativeness of our sample. Next. And just wanted to show this. So there's our fleet of vans at the OSU Cascades campus last weekend. These 12 passenger vans. It's a pretty impressive image when we saw them in the parking lot in one spot. And we see them all over town. People have seen them all over town in Corvallis and Bend. It's kind of a fun sight. Next, please. So at the doorstep, the team leads knock on the door. They take a step back. They all adhere to social distancing in the field between them and the household as well as each other. Introduce themselves in the project. They'll do an eligibility screen. They'll provide participants with the consent forms and be there to answer questions and walk them through the process. They'll conduct a short interview, which includes contact information, symptom check, as well as some basic demographics the lab needs to include in its report to the county and state. They'll work, again, this is a self nasal swab specimen collection, so they'll work with the participants, kind of walk them through that. We have written instructions as well for them to use. And I touched on the last point already. So next slide, please. And then I'm going to turn it back over to Ben to talk about lab and data entry and reporting, and go from there. Thanks.
Thanks, Jeff. Yeah, so the field teams will, throughout their day, they'll come back to the to home base to drop off samples that have been collected. What's actually collected, what we have, right, is we'll have a consent form, the survey form, which contains the patient, the participant information that Jeff was discussing, and then the actual sample. Those get checked in, and then they sort of get routed to the different pieces of trace ops that need them. So on the left here, you'll see our wonderful data entry team that Brett Tyler and Denise Hines, Kirsten Carroll, and Justin Priest coordinate, and it's staffed by I think predominantly by OSU students, but other members of OSU community as well. And they work really hard and really long to get all the data entered from upwards of 600 surveys a weekend, to get that all entered into our database as the weekend is going on. So by Sunday, Monday, we have all that data entered, because we're in a race against the clock to get both to get the population level estimates out for public health, but really also probably most importantly to get results back to the individual participants. And so to even get that process started, in the lab, you need the participant information. So that goes over to the lab. Justin Sanders heads our lab operations in collaboration with Willamette Valley Toxicology, Oregon Veterinary Diagnostic Lab, and so those samples begin their journey. Viral RNA is extracted from the samples. It's run through the qPCR process so that we can, using an FDA authorized test to look for signs of the COVID-19 or the SARS-CoV-2 virus. And the diagnostic results are matched back up with the participant information, and we begin the notification process, which is actually handled by the same set of folks that run the data entry side. Participants receive a mail notification, definitely, but then they can also opt into an email-based notification. At about that time, the trace analysis team spins up, and we start running the prevalence models that convert the data on the number of samples we collected and the number that were positive and other sources of information into an estimate of what the viral prevalence is that weekend for the whole community. On the communication side, I think we've mentioned the call center, which is available for anyone who has questions about the project, and especially participants. So you can see the socially distanced call center in the alumni center that's on the right there. Before sampling, though, OSU University Relations and Marketing team broadcasts messages about trace widely to the community, to stakeholders. And,
sorry, Ben, we are
Oh, Javier, did you have something to say? Jeff, can you hear me?
I can hear you. Yeah, I think you might want to probably just keep going, I think.
Okay. I wonder what Javier's message is. Okay. So University Relations and Marketing, Steve Clark, who's the vice president for that, works really hard basically all the time for Trace. Beforehand, it's getting the message out to the community, to members of the media, to stakeholders about what we're doing. During the weekend and after, it's helping us connect with members of the media to be able to communicate what we're doing, helping us develop how our presentation of the results of the analysis. So it's a constant. The communication aspect of it is really big and important, and I want to especially acknowledge Steve and Allison for their work on that. We have a website, trace.oregonstate.edu, that has a lot of information. Okay, so a little bit on the results to date, and I'm going to start with community engagement results. So we were out in Corvallis for 3 weekends so far before moving to Bend. So April 25th, May 2nd, and May 9th. The first weekend, we fielded 16 teams, and after that, we moved to 30 teams. But we made the first weekend, we asked the 16 teams to work double time. And so we got 30 neighborhoods covered in each of those 3 weekends. And that in each of the 3 weekends, we're looking at hundreds and hundreds of households. So in the first weekend, it was 237, then 359, and 346 households. As many individuals as are eligible and as are as want to participate in a household can, so there's no upper cap there. Kids too, if they assent. And we have had really, really high participation rates, for which we're really grateful. So for participation rates, right around 80% across the 3 weekends in Corvallis. Across those 250 to 350 households, we've gotten 450 samples our first weekend, 672 our second, and 649 our third. In terms of the raw number of positives, in the first weekend, and I'll come back to why it's presented this way in a second. In the first weekend, we had between 1 and 9 positives. In the second weekend, 0, and in the third weekend, 0. So these are not in themselves estimates of prevalence. This is just the underlying data. The reason that we say 1 to 9 and not the actual number is to be conservative with respect to participant privacy. If we had just a few positives and we were to share the actual number, it's possible that that would be a part of a potential process that would lead to those folks being identified if other information about them was shared from another source. And so we follow what Bend County Health and what Oregon Health Authority does in, when we have 0 cases, we just say 0 positive tests. And when we have between 1 and 9, we keep it in that bracket just to be conservative about participant privacy. So how do we go from those data, a number of samples and a number of positives, to an estimate of prevalence for the whole community? Well, we use, I'll go over this at a high level and then happy to go into it in more detail if it's of interest to folks in the audience. We use a Bayesian approach. We use something called a beta binomial model, which takes the testing data and combines it with a prior expectation on prevalence. Now, we leave that relatively uninformative. We don't want to pigeonhole what we think prevalence is, but we also know something about prevalence, and it's important to add that into the model, right? We know prevalence is not 80%. We also know it's not 0 because we have cases confirmed in the hospital. So prior information on prevalence and incorporating that in is important. So we combine that with our testing, our sampling data, using the beta binomial model. For stats nerds, is actually kind of like the hello world of Bayesian models. It's a lovely, simple model that is appropriate in this case. And we're developing actually more detailed, complicated models as well. This is sort of what we're using as we go, and it works especially well when we're really getting back so few positives. What we had planned to do when we were thinking, we might get more positives, is start to estimate differences in prevalences among neighborhoods, and that's not something that you can do if you are looking at all zeros, although it's wonderful to have all zeros from every other perspective. And so we run the model at both the individual and the household levels, because we know that infections cluster. So if one person in a household is infected, unfortunately, it's quite likely that other members either have been infected or will be. So we look at both the individual as a unit and also run the analysis looking at the household as the unit. And we also consider the impact of test sensitivity. So we know that there are going to be some false negatives, as with any test. Okay, and so here I want to highlight the contribution of Peter Banworth, who's an epidemiologist and analyst with Bend County Health Department, who works on the trace analysis team. And this is another example of our partnership between the university and a stakeholder in the community. Okay, so some results. So this is a little bit of a busy slide, and I'll just spend a few minutes on it. If we just focus on the left-hand graph, this is doing the analysis at the level of individuals. On the vertical axis there, we have prevalence per 1,000 population. And now the bars, we have these three groups of bars, here, here, and here. These are the different dates. And then we have three different colors are the lower, the median, and the upper bound of our confidence interval estimate for what we think prevalence is. In the language of the Bayesian model, it's the posterior distribution on prevalence. And so we're 95% confident that the prevalence is below the yellow bar, and we're 95% confident that it's above the red bar, and then the blue is our median estimate there. And then just going over to the right graph for a second, the paler color here is showing the difference between assuming a perfectly sensitive test, so no false negatives, and a 60% mean sensitivity, which is a little bit on the conservative side, but what data evidence indicates the testing performance, could potentially be. So this is just looking at, obviously, the more false negatives you have, the more you are underestimating prevalence. So when we go from assuming a perfectly sensitive test to one with a 60% sensitivity, we see an increase in prevalence. And so you can understand the potential impact of testing diagnostic sensitivity on our results there. And so what do we have? What we're looking at in the first weekend, we were just sitting around, between 1 in 1,000 and 2 in 1,000. And then over successive weekends, we dropped down to our median estimate being below 1 in 1,000. Now notice it's not 0, right? And that's because even though we got 0 positives, we have prior information. We know that there's cases out there, and that's being factored in to give us a non-zero estimate there. So yeah. On the right-hand side, we repeat the analysis using households. So looking at, instead of the outcome being a positive test from an individual, the outcome is a household with at least one infected individual, and similar estimates of prevalence there in terms of the pattern. Overall, as of May 9th, 10th, we're 95% confident, even with 60% imperfect sensitivity, that household and individual prevalence is below 5 in 1,000, and our median estimate is much lower than that, right around 1 in 1,000, or even lower. We are adding other streams of data to trace to complement the door-to-door aspect, and this is one of the high-level goals that we have is taking a bunch of different data streams from a city to really enhance epidemiological awareness. And one of the really exciting ones is to add wastewater. So it's possible to detect the virus in wastewater. This can be done, at the influent point at a wastewater treatment plant. It can be done at large facilities like hospitals, and it can be done in neighborhoods in collaboration with cities. And Tyler Rednecki and Christine Kelly and the College of Engineering have devised an innovative program that's doing just this in communities across Oregon. We're delighted to collaborate with them and have them be part of the TRACE project as well. And they were out with us in Bend last weekend, and going forward, we're going to be doing door-to-door and wastewater paired, and hopefully starting to learn how those two different signals of information relate to each other, so that eventually in places where we can't do door-to-door sampling, we can use the wastewater as an early warning system and be able to understand something about what that indicates about the prevalence that you would find if you went door-to-door. Okay, Jeff, are you taking over again here? I can't remember.
Sure. I'll do it. Yeah, just some implications real fast. We'll wrap this up. Leave time for questions. Ben showed the results from Corvallis, indicating relatively low prevalence. But I mean, it does demonstrate that coronavirus is in the community, consistent with other sources of testing information. But I think the message is that demonstrating that the coronavirus is in the community means that there are infections out there which could serve as a foundation for future growth, particularly as we open up. And we're going to phase 2 today, I believe. And so similarly, it's really important to conduct these kind of rapid health assessments, these quick cross-sectional estimates of infection in Oregon, throughout the country, as we open up, to see, beyond just people who are symptomatic and presenting to healthcare facilities for testing, what is the community-wide estimate of infection. And I tried to advance again here on my computer. That's not going to work. Thanks, Ben. So yeah, next step. So from the very beginning, we'd always envisioned traces, developing it to serve as a template for others to replicate across the country. And that's still in our plans. I think we get people interested in our methods, so we're looking to share how we pulled this off and how we're doing this with others. And also we envision trace, potentially following up for when hotspots are identified through other surveillance means. Trace, we're pretty nimble, given how big we are. We're pretty nimble to respond to a identification of a hotspot in Oregon. And lastly, just a statement. You may have seen the notice from information from the provost that the testing of the OSU community and trace, the larger trace, is going to be involved in that. So that's some of our next steps. Last slide, Ben. And here's the beautiful OSU Cascades campus. Here's our field team from last weekend. Photo by Aslan Oaks, our field operations manager. Be sure to highlight that. It's a beautiful campus, and this is a really cool shot of everybody getting ready to go out the morning of. So one more click, Ben, and I think we're ready for questions. Thank you.
Well, thank you, Jeff and Ben. I apologize for earlier. I was dropped from the call. I thought it was Ben who was having these communication issues, but it turns out it was me. But hopefully, I will stay on. So I have a couple of questions from Arpita Mukherjee. I hope I'm pronouncing your name correctly. I'm sorry. 2 questions. How the clusters were formed? That's the first question. And the second, households were samples, not individuals. Individuals within a household are correlated. How did you tackle this in the analysis? And also how the non-response was addressed?
I'll take the first one. Clusters were formed using 2010 census data at the block level. So we obtained block level, block level, the number of households, housing units for each block in Corvallis. And we used, we identified essentially 30 random numbers between 1 and the number of housing units in Corvallis, and that corresponded to 30 different census blocks, with the larger ones having a rare probability of being selected. We grouped census blocks so that the minimum number was 50. So so small ones, so 50 was the minimum. Again, using 2010 census data. And I'll let Ben address the correlation individual and household, which I think he did in the presentation, but go ahead.
Sure. So I'm not 100% sure I metabolized the question, but I'll take a shot at it. Right. So when we do the analysis at what we were calling the household level, the way that we're doing that right now is to create a new response variable that just says, looks at the prevalent, the number of households with greater than 1, or with 1 or greater positive tests. And so the whole analysis is done with a household as the unit, and it can either be sort of 0 if there's no positive tests, or scored as a 1 if there's 1 or more. We're working on more nuanced analyses, especially ones that are robust to getting very few positives back. And maybe I'll leave that there for now, but invite follow-up questions, of course.
Question from Caroline Alwyn. Did your sampling frame include skilled nursing facilities? I believe that most of the cases in Oregon are in that context.
Yeah, thanks, Carolyn. Congregate living facilities of various types were excluded from our second stage of sampling, as well as obviously businesses, government offices, things like that. So large group congregate living were excluded. So we recognize, it's a good point that that's where a lot of the cases are coming from. But we, in terms of we really couldn't gain entrance to those facilities is one reason why they were excluded.
Thank you. Question from Heather Fulton Bennett. What's the main reason for people, sorry, I lost it, for people not agreeing to be tested? Yeah,
we didn't track that. At least when I was with teams in the fields, I didn't see maybe 80% participation rate was really high. So I'm just listened nicely and said no thanks. I was with one team in Bend. The person said, "Yeah, we saw you on TV. We're not interested," and that was it. So the refusals have been succinct, but pleasant for the most part.
Thank you. Brevity in your answers, Jeff. You're doing great because questions are coming fast and furious. So
let's go.
That's great. So another question from an anonymous attendee. Can you talk please about messaging specifically, quote, well, the TRACE project hasn't found any cases. So why can't we gather in large groups? What has OSU done about this? And what language can the rest of us use to explain how 0 is not equal to 0?
So I could take a shot at that first. That's a really important question. We grappled a lot with it. So thanks. 0. So that 0 not equal to 0 thing. I think that the way that we look at that is 0 positive tests is not equal to 0 prevalence. We know that the prevalence is not 0. So those are different things. I think as the question is indicating, but it is tricky to message. I think that there's sort of two sides in it. So if we look at our prevalence estimate of 1 in 1,000, 1 in 1,000 is low relative to what we've seen at other places and times. It's consistent with the idea that the sacrifices that people have made for physical distancing have been effective in flattening the curve in Oregon. At the same time, from an epidemic dynamic perspective, 1 in 1,000 is plenty high enough that we could enter another phase of exponential growth if we reopened too quickly. So it's not a negligible prevalence from the perspective of the risk of more cases down the road, but it is low, and we can be grateful for that. So I think the other thing I would add is that, and we're just sort of we're just chewing on this now, I think, but we're starting to realize, and this is consistent with some data that OHA released just recently, the population that we are interfacing right now does have a really low prevalence, but there are cases out there, but they're in specific contexts, right? So in jails, for example. And so talking about the prevalence of a whole city, I think going forward, we need to find ways to account for the fact that we do have pockets of high prevalence amidst a population where there's a significant component of it that has low prevalence. And there's a heterogeneity there that I'd like to see us tackle somehow going forward. So that's part of it too. I know I'm not being brief like Jeff, so Jeff should take the questions.
Thank you. So a question from Paul Mortag. Given that you are not trying to estimate the effects of covariates on prevalence, why not just use a design-based estimate of prevalence instead of the more complicated model-based approach that you appear to be using?
Yeah, right now the model doesn't have covariates in it. The function performed by the model is simply to combine prior information on prevalence with our data in a principled way.
Another question from an anonymous attendee. Do you have plans to expand TRACE to other communities in Oregon?
Yes. No, I will say more than that. Yeah, that's always been the plan is to do this, to expand beyond Corvallis. Bend has been our first city beyond Corvallis, and we certainly have aspirations and plans to go elsewhere. Funding dependent.
Another question, anonymous attendee: is the contribution of trace mainly to quantify the prevalence of the virus, what we didn't know before?
Do you want to go first and I'll go second? Either way, it's good with me. Sorry.
Yeah, it depends on what you mean. Yeah, I mean, we're trying to determine an estimate of infection in a community, prevalence. We really think of it as like a signal. Again, this is a rapid health assessment. We're looking for a signal of infection in the community that, again, our partners, the health department, can use to make decisions, to track over time. So again, as we go into our fourth weekend of Corvallis, we deliberately delayed that a bit to a point where things have changed as we're opening up, and we can get another signal when we launch that fourth week.
Yeah, and I might just add to that maybe it's not, if we come back and we say, the prevalence is 1 in 1,000 or it's 2 in 1,000, whether it's 1 or 2, maybe that's not the most important thing. There's as Jeff alluded to, like the ability to know rapidly how it's changing over time is important. And also, I think that we've been talking more within Trace about the notion of a prevalence ceiling, being able to say, like, even though we have a finite sample, we're really confident that the prevalence is lower than X. That seems to be a type of information that's also being useful. And maybe in some senses, in some cases, more useful than knowing a very high precision on the median prevalence.
We have only 3 more minutes, and I'm going to skip questions to some of the people who have not asked questions before. My apologies. This one from Sarah Henkel: how does the sensitivity of the test, the trace tested individuals are self-administering, compare to the deep swabs that are being used in the various testing centers?
Yeah, that's a good question. So there's increasing evidence that the nasal swab that we're doing, which is just a little bit inside your nose, as opposed to the nasopharyngeal swab that you see on TV that sort of swabs your very thoughts. There's increasing evidence that the nasal swabs are performant. They don't have perfect sensitivity, but a lot of the sensitivity of these tests in this context is driven by the viral load of the participant, and that's really variable, right, over time. And so that drives detection ability across a range of different tests. But it's a tricky issue. So and there's more evidence coming out all the time. But I think the trend that we've clearly seen is an increasing willingness to embrace nasal swabs instead of nasopharyngeal swabs by the public health community and authorities, and that's consistent with the evidence, I think, in general.
Yeah, there are a couple of more questions on sensitivity of the test as potential, but you kind of answered already that. Perhaps another question: how are the health departments using your information?
So in the case of locally, Benton County Health Department, they've been partners in this all along. Ben mentioned Peter Banworth is part of our, consult or working with our analysis team. How they're using it, I think is probably can be directed to them. But I think this estimate, this relatively low prevalence, is helping them, have a better idea of the current situation in Corvallis. Again, this was another question kind of alludes to this. These 3 weekends of data collection were conducted on weekends in which Corvallis was relatively, locked down. So I think seeing relatively low prevalence was consistent with that environment. And again, as we go to the next one, I think we'll provide even more useful information to the county and see how things are changing.
Well, one more question. We are out of time almost. I'm sorry, I have to leave some without, there's no time, but how does this project relate to the Key to Oregon project?
Yeah, so we see those projects, and I think they do too, as really complementary. We are boots on the ground rapid health assessment, and they, community by community, partnering with local communities and health departments. Key to Oregon, statewide, and engaging participants in a different way that yields a different type of information. And also really just, I think, in the early phases there too. So we speak with them regularly and are working on ways that we can leverage the synergies between the two projects.
Well, time is up. I'm sorry, I have to conclude. We have to conclude. But again, thank you, Ben and Jeff, for this presentation, and everybody who attended and for your questions. Thank you very much, and have a great weekend, everybody.